particularly among the active and elderly population, often resulting from falls, sports activities, or motor vehicle accidents. These injuries can significantly impair mobility and, if not properly managed, may lead to chronic pain, arthritis, and long-term disability. Traditional open reduction and internal fixation has been gold standard for the treating the displaced ankle fractures, providing reliable outcomes through direct visualization and stabilization of the fracture site. However, open reduction internal fixation is associated with notable drawbacks, including extensive soft tissue dissection, higher risk of wound complications, and prolonged recovery periods. In recent years, there has been a paradigm shift towards the minimally invasive surgical techniques in the management of ankle fracture. The evaluation of the surgical technology, improved imaging modalities, and refined surgical skills have facilitated an adoption of the minimally invasive surgical approaches. These techniques aim to achieve comparable or superior clinical outcomes to open reduction and internal fixation. Good morning, sir. Topic is advancement in minimally invasive surgical techniques for ankle fractures. Clinical study. These techniques aim to achieve comparable or superior clinical outcomes to open reduction and internal fixation, while minimizing the tissue trauma, reducing intraoperative blood loss, and expediting patient recovery. Minimally invasive techniques such as percutaneous fixation, arthroscopic assisted reduction, and minimally invasive plating has been increasingly explored and implemented. These approaches offer potential for smaller incision, decreased postoperative pain, shorter hospital stay, and quicker return to the functional activities. Despite the promising benefits, minimally invasive surgical techniques present unique challenges, including steep learning curve, limited visibility, and potential technical difficulties during the fracture reduction and fixation. This clinical review aimed to critically examine the advancement in minimally invasive surgical techniques for ankle fractures. By analyzing recent literature, this review will assess the efficacy, benefits, and potential complications of minimally invasive surgical compared to the traditional open reduction and internal fixation. Traditionally, open reduction and internal fixation has been cornerstone of the surgical management for the displaced ankle fractures. This method involves the substantial surgical exposure to allow the direct visualization and manipulation of fracture fragments, followed by the internal fixation with plates and screws. While open reduction and internal fixation has been proven effective in achieving the satisfactory fracture healing and functional outcomes, it is not without limitation. The extensive soft tissue dissection required for the open reduction and internal fixation increases the risk of wound complications, infection, and delayed healing. Additionally, the recovery period can prolong, impacting the patient return to daily activities and work. In response to these challenges, minimally invasive surgical techniques have gained traction in alternative approach to the ankle fracture management. Minimally invasive surgical techniques are designed to minimize the surgical trauma by using smaller incision, reducing the soft tissue disruption, and employing the advanced imaging modalities to assist the fracture reduction and fixation. These methods include percutaneous fixation, which involves the insertion of the screws or pins through the smaller skin incision. Arthroscopic assisted reduction, which uses the camera and instruments inserted through the small portals to visualize and treat the intra-articular fractures. Minimally invasive plating, which combines the principles of traditional plating with less invasive surgical access. Methods. It is a comprehensive literature search was conducted to identify studies published in the last decade that evaluated minimally invasive surgical techniques for ankle fractures. Based on relevant clinical trials, cohort studies, and case series were reviewed to compare the outcomes such as fracture healing, functional recovery, complication rate, and patient satisfaction between the minimally invasive surgical techniques and traditional open reduction and internal fixation. Discussion. The advent of the minimally invasive surgical techniques in the treatment of ankle fracture represent a significant shift in the orthopedic surgery, aiming to చేసిన సార్ అది ఆల్మోస్ట్ అట్లే ఉన్నాయి అవి aiming to enhance the patient outcomes by minimizing the adverse effects associated with traditional. The discussion synthesizes the finding from recent studies, evaluated comparative benefits and challenges of the minimally invasive surgical techniques, and consider the implications for the clinical practice and future risk. Clinical outcomes are comparison. This clinical studies are outcome, but yes, yes. Clinical studies are this is. No, sir. This is clinical study, sir. It is clinical study, and there is just. Sir, sir, just. Sir, just clinical study on the outcomes. Yes, clinical study. And clinically, open reduction has extensive soft tissue damage and wound complication. Infection rate more. Infection rate is more, sir, in open reduction. Yes. In minimally invasive, it has less complications like smaller incisions. Sir, yes, అందులో క్లినికల్ స్టడీ అని ఉంది టైటిల్. సార్ టైటిల్ ఉంది. రివ్యూ. ఎస్. Minimally, yes.
Multiple but paper and paper, sir. But here, what plates they have used here for the minimal invasive? Is the plate normally available here? We have very thick plates on it. Even now we are having what thick plates. You can't, get the plate underneath the skin. Especially fibula is such a small bone. Yes. Without opening the fibula, you can't do it. But at least it doesn't have much soft tissue to strip.
Yes.
No muscle cover. Submuscular stripping cannot be done for fibula. Ankle fractures. What you have done here with this technique? What fracture? Cotton fracture? Something else you have done? Ankle fractures, no? Or supramedullary fractures? Pylon fractures? What fractures you have done here? Ikkada. You have done open reduction with plate, some plate or what, MIS, whatever it is. Switch now ikkada.
It has got a very limited role, and it also depends upon the fracture configuration.
Yes.
Each and every fracture cannot be treated like that.
Yes.
Suppose there is a joint line in position. What do you do?
You want to put a plate? Is a plate or normal plate or a screw?
Transverse, clean transverse fracture of the medial canal.
So
No
open.
fibula fracture, no seamless multiplication. It's a purely
Abduction. Transverse fracture at the level of joint.
at the level of the joint.
What do you do? Put a cast and leave it?
Open reduction.
It's in position, good position, anatomic position.
For screws, open reduction.
You want
and
to open
fixation
reduction or just closed?
It is in good
Yeah.
position. Why not
Percutaneous, yes.
screw or a K-wire?
Percutaneous can be done.
Why? Why not?
Mm, soft tissue interposition.
What's up?
Periosteum. Yes.
But not
Periosteum
always,
interposition was
Sometimes it happens, but not always. You can just as well do percutaneous K-wire or the screw, whatever it is.
But we do not know.
Yeah.
In the C arm, even if it is anatomically reduced, there is very likely
yes.
that periosteal interposition is very likely in such injuries.
But if it get displaced, suppose displacement is more, there is a chance to get into that. But undisplaced one, I don't think it gets into the periosteum to the
What
cell.
happens in this mechanism, the talus gets laterally
Yeah, that time,
lifted,
right.
and then the fracture opens up.
That
Again
can
it
get
goes
into,
back
yes.
position.
That time it gets into it.
That time itself,
That's
periosteum
more,
will be
yeah. Part of,
transversely
part,
above the fracture line.
part of it can get into it, right.
Yes, sir.
But infolding cannot be assessed by a plate.
That's the only chance you take, otherwise, open.
Otherwise, the patient may come with a non-union at the end
Yeah,
of 2
6
months.
weeks, right.
Yes.
Even if you do percutaneous fixation.
What about fibula?
Below the syndesmotic joint, we can definitely fix the fibular fractures.
For tibia, or is it malleolus fracture or pylon fracture, is it ideal to put a MIS?
Based on the fracture configuration,
That's
we
what I'm
decide
saying. Undisplaced
patient factors.
supramalleolar fracture or a pylon fracture in 60, 70 years old female. So what do you want to do? You want to open it?
Yes.
Or percutaneous can do it. MIS. MIS can be done easily, no? If it's
Yes.
supramalleolar fracture or the pylon fracture, that's only indication there. And what difference is there? So they have studied with both the open reduction as well as the MIS, no?
Yes,
Which
sir.
is better, they say?
In clinical outcomes, minimally invasive surgical technique is better, sir.
And the rate of union or non-union rate more in that?
In the studies,
If you're not opening the middle malleus, there's chance of getting the non-union also because periosteum what it is.
yes, sir.
Yeah? There's incidence of non-union coming in middle malleus or the lateral malleus. With the MIS, is there a chance of getting a non-union?
Yes, sir.
Whereas an open reduction is very rare. But chance of infection is more in this or both are same? I think both are same. Infection rate, if you can't compare, both are same.
What are the guidelines for management of a pylon fracture?
You know what pylon fracture is, right?
Yes, sir. Yes.
What is the specific point that you will look for pylon fractures? You know the mechanism of pylon fracture.
No,
You know what pylon fracture is, right?
intra-articular extension was
Intraclear.
distal tibial.
Or not. Fall from a height, old people, you can get this supramalleolar fracture or the pylon fracture which is there.
Yes.
But
Yes.
but maximum edema is there. Unless the edema is completely gone, you don't touch the patient. That's what the wrinkle is.
Injury is very severe and they develop a lot of edema. The whole soft tissue envelope will be edematous because of the fracture hematoma bleeding from the cancellous bone into metaphyseal and the articular area. Articular termination will be quite significant. Soft tissue injury is more dangerous than the bone injury. So they are likely to develop
Compartment.
also. slab and leave it like that for 2-3 weeks, which is the time taken for developing the wrinkle sign. Would you put a slab and wait for the edema to subside?
No, sir. Yes, yes, sir.
By the time already the soft tissues, muscles will get contracted, including the ligaments around the joint, they get contracted, and at a later date when you want to do definitive fixation, you will not be able to reduce the articular combination. So the best way of managing it is an actional fixator on day one itself, spanning actional fixator, spanning the ankle, and the fibula also will be fractured in these cases with significant displacement. A minimal invasive plate to maintain the length of the leg. Tibia. Otherwise, at the end of 3 weeks, because it is a cancellous bone, you will not be able to reduce the fractured fragments. So the ligamentotaxis or so-called musculotaxis will be achieved by maintaining the length of the fibula with a
Minimal
plate,
plate.
low profile plate, and wait for the wrinkle sign to appear, and it also prevents the flex.
Yes.
Because we are trying to stretch the soft tissues which are crumpled. Then at the end of 3 weeks, we will have to do a definitive fixation by removing the Generally, you cannot achieve anatomic reduction.
Yes.
There will be significant depression. There will be 3 main fragments. Depends whether it is a C3 or C2 fracture, depends on the CT scan. So CT scan is mandatory in all these cases. Definitive fixation depending on the fragments, the anterolateral approach or anterolateral plate, L-shaped plate, or posterolateral. You have to decide on the fracture configuration.
Yes.
The initial fixation with
External.
fixator, spanning X-fix,
Yes.
is the ideal way of
Can,
will not work out.
yeah, can the X-fix also produce compartment syndrome or not?
No, sir.
No. Why? Putting multiple pins in this already injured one, it can get sometimes. The best thing is to watch for that. Just putting it and again putting a traction and put this special and then X-fix, it may produce more damage to that. So that has to be taken care of. It can be there. But elevate the limb maximum to get the edema reduced. That's what the thing is.
But the pins for the X-fix in this type of configuration will be too proximal, not in the distal
Distal.
third. It has to go a little more proximally
Okay, sir.
to reduce further soft tissue injury.
Yes, sir.
Plates, the same, all throughout the same width is there, or the periphery or the end that is sharp and then Vishnava. What you are having is all the uniform plates. If the MIS plate should be, the both ends should be sharp enough to go through that easily, stripped periosteum with that. Here what you are having is not that. The problem is that only. Those plates are different.
Yes.
You are having the bend one.
Smaller incisions and less extensive dissection preserve integrity of the surrounding tissues, which is particularly beneficial in the context of the delicate anatomy of the ankle. Reduced soft tissue trauma translates to lower postoperative pain, which can help patient recovery and rehabilitation. Studies consistently report shorter hospital stay for patient undergoing minimally invasive surgical compared to those treated with open reduction.
Anything else is there to talk?
I think it's
What is the size of this font?
30.
30, yeah. 35.
Should at least 40%.
That is okay. Not even a
32,
single photograph they kept for anything else.
Yes, sir.
That is too big a font for this slide. Yes. Next, X-rays.
అయిపోయిందిగా
అంతే
నేనే
సార్,
చెప్తా
దీనికి ఎలా-
అదే చెప్తాను చెప్పింది చెప్తున్నాడు.
Yes, sir. Advancement in the minimally invasive surgical technique offer promising alternative to the traditional open reduction and internal fixation with potential benefits in terms of soft tissue damage, lower complication and faster recovery. However, in the successful implementation of these techniques require addressing the technical challenges and ensuring the adequate surgeon training. Future research and technological advancement will likely expand the indications and improve the efficacy of the minimally invasive surgical techniques, ultimately enhancing the standard of care for patient with ankle fractures.
X-rays.
It is not only minimally invasive, there are certain things called endoscopy, minimally invasive endoscopic surgeries. For the universal exam question, one for the arthroscope, one for the surgeon photo. That is also the minimally invasive endoscopic surgery.
Okay, sir.
X-rays, please.
Endoscopic surgeries are different from arthroscopy. One for the scope, one for the instrument.
39-year male with grade 2 compound distal third both bone fracture of the right leg and grade 3B compound base of the third metacarpal fracture and proximal phalanx fracture of the third finger.
Nature of injury.
Road traffic accidents.
అన్ని రోడ్ స్పోర్ట్ మీద పడ్డ రోడ్ ట్రాఫిక్.
Highway loss.
Fall from a bike.
Fall from bikes.
High velocity injury or low velocity injury or that matters. The violence should be quite severe.
Yes, sir. No, sir.
Being caught by a metallic sharp object.
Describe the injury. What is it? Is it national? Finger injury or a mangled injury?
It is not a mangled injury, sir. Lacerated wound present over the dorsum of the hand. Sir?
What did happen? Something run over the hand or
Where was the hand got caught?
No, sir. They said bike versus bike.
Is it a contaminated or clean wound?
Contaminated wounds.
Contaminated with what?
With road dust.
Dust or trees?
No, sir. Dust on this.
Is driving a two-wheeler?
Yes, sir. Two-wheeler, sir. He is on.
Real driver?
Sir?
Was it hit? He has hit the road divider?
No, sir.
Hit
Bike.
the wall?
Bike versus
Or
bikes.
collision with another vehicle?
Collision with another vehicles.
What vehicle?
Bike only, sir. Bike versus bike. Yes, sir. For this we have done closure reduction internal fixation with island for the right tibia and K-wire fix 1.5 mm K-wire for the proximal phalanx of third finger and 1.8 mm K-wire for the third metacarp. Base of metacarpal was present. Proximal phalanx fracture was present. Yes, the combination is there. Here on.
Other ways to put anything, how to treat this case alone, wound is here. Can put X-rays here?
Can fix. Yes.
This can be only one camera across. This can be X-rays only here. Or wound will just put a slab within the wound. I think it is
A lot of soft tissue attachment there. If you do deployment and close, is there any skin loss?
Yes, sir. Skin loss was present. Yes, sir.
You have closed it.
But we.
Okay, when was the nailing done?
Sir, immediately, sir. Next day morning after. అంటే
Is it safe to do the nailing?
unremoved nails, we have put unremoved nails.
Why an external fixation was not thought of? Because the soft tissue angle appears to be quite considerable.
Yes, sir.
So you are confident of your debridement.
Yes.
It's a 59-year-old male with compound grade 3B distal both bone fracture of right leg and compound grade 3B fracture of first metatarsal and second metatarsal of left foot, sir. His contralateral side. Nature of history is he says that while he was traveling in the auto, he put his both legs outside, sir, and he was hit by a bike. We have an external fixator for the right tibia and rational for the fibula and K-wire for the first metatarsal, sir.
A 26-year female with closed distal third sharp fracture of the right ulna. It is isolated ulna fracture, sir. For this we have done open reduction and internal fixation with plating for right ulna, sir.
Nature of injury.
Assault, sir. Assault. Nightstick injury, sir. Also. Yes, sir. She too.
For any fracture, you have to tell the nature of fracture.
Okay, sir.
Injury, clinical picture.
Okay, sir.
Until proved otherwise, they are all assault fractures.
Okay.
Was it done in the night or the day?
Day only, sir.
Daytime.
Yes.
Was there a need for surgery for that case? Go back.
Yes, sir. It is comminuted fracture. But it is displaced and comminution was
How old is the patient? 26.
26.
It's an 11-year-old post-op follow-up case of middle third shaft fracture of left femur with implant in situ. We had an implant removal, sir, for the left femur. This is just a patient indication, sir. He has pain and it's just a patient indication.
75-year-old male with intertrochanteric fracture of right femur, sir. It is Boyd Griffin type 2. It is avulsion of lesser trochanter was present. For this we have done closure reduction internal fixation with long PFN, sir. 28 years male with 6 years old post-op follow-up case of closed middle third both bone shaft fracture of right leg with implant in situ. Patient complains of pain in knees, sir. That's why we have done implant removals.
White brown, go back. White brown. Where was it done?
Here only, sir. 6 years back. Yes, sir. Knee pain was.
Okay, next.
It's a 45-year-old female with subtrochanteric fracture of left femur, sir. This is instrument classification type 4. We had an open reduction internal fixation with long PFN, sir. 31-year-old closed supracondylar fracture of right femur with intra-articular extension. It's a Muller classification type C3. Intra-articular combination and metaphyseal combination is there.
Type C3.
Yes, sir. Yes, sir. Intra-articular combination along with the metaphyseal combination. Intra-articular combination and metaphyseal combination, sir.
Articular combination is not that much.
Yes,
More
sir.
of metaphyseal.
But anyway,
Yes, sir.
definition, so it comes.
Yes, sir.
No for component is there.
Yes, sir. How for component is?
X-ray itself.
It is there, sir.
Small one.
Is it lateral condyle or medial condyle? Can you say and lateral whether it is lateral or medial condyle?
It is a medial condyle, sir. Here we can.
What are the guidelines?
No, no, sir. Yes, sir. It is.
Medial condyle will be always at a lower level than the lateral.
And you can see APV also, it's coming from the medial condyle. Okay. What was that?
We had an open injection, sir. Through. Yes, sir.
How bad is the articular communication? Not much of articular communication, mostly of metaphysics. See the center row. Metaphysical communication is more than the
PowerPoint.
slide.
So,
We had an open injection through medial parapatellar approach and plating for the right femur, sir.
full screen.
Sir? Yes, sir. Minimal invasive only. Yes, sir. No, sir. We didn't open completely. Yes, sir. Minimal invasive.
Clips you can see only probably 60%. Still there is an inflection component. Femur is bowed. Looks good. Anyway.
So how far is fixed rate?
Hyper screws, sir. We had an hyper screws for the interarticular combination along with the Hoffa's fragment, sir. Yes. Lateral Hoffa, sir. Portfolio loan male with a trimalar fracture of left ankle joint, sir. It is a supination action rotation type of injury. We had an open injection with plating for fibula and malleolar screws for middle malleolus, sir. Sir? No, sir, not fixed. It is an extra-articular component. Yes, sir.
If you fix it, you can mobilize very early. Don't fix it, you have to mobilize correctly. 3 to 4 weeks will take to do. So the advantage of ORIF is partly defeated.
What type of mechanism injury, triangle of fracture, supination,
Supination external rotation.
pronation, external.
This is supination external rotation, sir.
What is the difference between posterior malleolar fracture, whatever you say, trimalleolar fracture with Workman's fracture? What is the mechanism of difference?
Workman's.
Trimalleolar fracture is also called as Cotton's fracture.
Oh, sir.
Workman fracture is called as posterior malleolar fracture. What is the difference? Your question is clear?
Yes, sir. In trimallar, it is due to rotational injury like supination action rotation. Posterior malleolar, there will not be any rotational injury. Direct fall, so direct trauma.
Is there any quadrimalleolar fracture?
Yes, sir. Along with, if it is along with chaput or Wangstaff fracture, it is called a quadrimalleolar fracture.
What is it?
If the trimallear along with the chaput or Wangstaff, chaput fracture, sir. Chaput fragment. That is a anterior fragment of tibia. Yes, sir. Tilaks. Oh, sir.
Don't hold the mic.
Okay, sir.
Please.
Or Wangstaff fracture, if it is included with the trimalleolar, it is called quadrimalleolar. Yes, sir. Yes, sir. We can't, sir.
going, sir. These are the X-rays done in Unit 2, sir.
Louder.
23 years female, 2 years old post-op case of proximal third of shaft fracture of left femur, sir, with implant in situ IL. But an implant removal.
What is that circular? Is it related to the implant?
No, sir.
What is it? It is in the, is it in the pocket?
Here in the lateral view.
And
It's away from that. Okay. Okay, next.
Only one case.
yes, sir.
So good morning, sir. This is 65-year male with 5-day-old grade 2 compound both bone fracture of the right leg.
Grade 2 now. Laceration on
Yes, sir.
A part of the leg is you'll have to include most of the leg, otherwise you do not know which part of the leg is
Sir,
injured.
legal. Yes, sir. Outside. It was done outside, sir. We removed the sutures.
Okay.
Okay.
For this close reduction internal fixation with ILN, sir. ILN was done.
Can it be treated conservatively? Go back.
Don't use short forms. Other day everybody using short forms in
Okay, sir.
exams. Right.
After the wound has healed, can it be treated with Sarmiento?
Both the cortex were reached, sir.
See, any fracture can be treated with non-operative. You know. It's only, you see, some are treated, must be treated with operative. Please. Sir is asking, can you treat? Means yes, we can treat.
Okay.
What is?
Away from the...
Huh? What is Sarmiento? Raghu? Huh? Telida? Huh? What is Sarmiento? He's a surgeon, orthopedic surgeon. Huh? He has described this technique of functional cast bracing in 1977.
And he used to treat all fractures with plaster and early mobilization. Any fibular fracture here?
Old fibular fracture, sir.
Huh? Fresh one. So that's indication for surgery as well. Isolated fracture, chances of delay non-linear are high.
Sir.
Anybody know the principle of functional cast bracing?
Everybody should know.
Have you applied a PTB cast any time?
Yes, sir.
Huh? Not knowing what is it. Okay. You have to read.
There is a book, small book in the library. Is there Sarmiento? Must read that book. Next one. Or ask Dr. J. Krishna to present a class next Thursday. You teach them about Sarmiento.
30 years male with closed.
You can only ask them what we taught. You can't ask them what we did not teach them. Adhe kada. Go on.
30 years male with closed patellar fracture of right knee, sir. It's a road traffic accident, directly fall on the right knee, sir. It's a transfers with a fragment, sir. AOTA 34 C2, sir. Stellate fracture. Yes, sir.
It's a stellate.
Stellate fracture.
Are there any telltale signs like abrasions?
No, sir.
Is it a direct injury or indirect?
Direct
He
injuries.
fell directly on the...
Directly on the right knee.
What are the types of the fracture of the patella that you expect in indirect violence?
Avulsion fracture, sir, from superior pole and inferior pole, sir. Lateral
Other types.
transverse fracture,
Put the mic.
transverse fractures,
Transverse fractures.
transverse fractures.
Did you examine whether the patient was able to actually extend the knee at the time?
Yes, sir, he was not unable to extend the knee, sir. Extensor mechanism loss.
These injuries, the extensor mechanism will be relatively intact.
Unless it's grossly displaced, it will be.
See, the whole of the body of the patella, including the medial facet, is intact. And the parapatellar retinacula, even the expansion, quadriceps expansion on the anterior surface of the patella will be intact. Though there appears to be a little gaping here, this gaping is probably because of the lateral condension and
Maybe articular surface may be intact.
so usually the soft tissues will be intact. Probably he did not do that because of the pain.
Yeah, possibly.
We can treat with tension band wiring, sir. Due to intra-articular, it should be treated. But due to comminution, we have surgery was done, sir. Tension band wiring, sir. Sir? Tension band wiring, sir.
Articular surface.
You are not supposed to bend both ends of the wire. Very difficult to remove them.
Yes.
Will you want to remove them?
After how long duration?
1 year, sir.
Huh?
1 year.
6 months.
Move the knee, that only shows the hardware will come out soon. So whenever it is coming out, you have to remove all these things. Otherwise, problem comes. So the function of the TBW is that only. Whenever, yeah, that means he is actively moving his knees so that the hardware pops out. That has to be removed that time. Not 1 year, 6 months also.
He has to continue the range of movements of the knee, sir. Flexion and extension range of movements of the knee. He has to continue immediately after these surgeries. No, sir. We allowed him to do physiotherapy.
Not tablets.
75, sir. 75 male with intertrochanteric fracture of the right femur. This is Borden Griffith type 2, sir.
What else is there?
Sir.
X-rays.
Osteoarthritis of the hip joint, sir, right hip, and looks highly sclerosed avian of the bilateral hip, sir.
Is it avian or sir?
Osteoarthritis, sir, along with highly sclerotic. It is highly sclerotic, so it appears.
Sclerotic, there is nothing like highly sclerotic. Yes, what is it?
It is sclerotic. It appears sclerotic, sir.
So my
And the joint space between the
joint space is
reduced.
may not be avian because there is no collapse of the head, femoral head. Okay. Was he complaining of pain before the fall?
No, sir, no complaints of pains.
75.
Yes, sir.
Blood.
Close reduction, internal fixation with proximal femoral nail was done for the right femur.
Opening is there. Reduction is not satisfactory. Okay.
Sir, 47-year male with a grade 3B compound both bone fracture of left legs. Fall from bike, sir. We have done external fixation for left tibia, sir.
Wood was not good.
This is
Nailing was not done.
compound fracture, sir.
And there is a screw proximal bone. Why is that?
The tibial plateau, sir.
That also.
Plateau, sir. Yes.
Okay.
This is post-operative day 2 pictures. Wound.
The wound appears to be quite clean. See,
You could have done a nailing, left you wound open.
the margins appears to be very regular, not irregular like a very bad laceration.
And the clean.
And the soft tissue damage, periosteum appears to be intact. Appears to be intact.
No treatment justified.
After suturing it appears to be more ragged than the original wound. Skin margins should have been trimmed.
Next.
64 years male with intertrochanteric fracture of left femur, sir. It's body Griffin type 1, sir. We have done closure reduction internal fixation with PFN for left femur, sir.
So many too many, I think we should follow them up. Are we following them up? No. This was thesis for somebody. Then one of you should do. How many, what is the rate of failure?
And we can also study the bowing also. The amount of bowing, the age incidence.
Okay.
16 years male with grade 1 compound middle distal third junction shaft fracture of right tibia and fibula, sir. And lateral condyle tibial avulsion fracture with fibular head fracture, sir.
No neurovascular, no.
No, sir. No foot drop, sir. No disc.
MCL, LCL,
Avulsion is, sir. Sigon fracture. We have done closure reduction internal fixation with ILN for right tibia, sir. And it was done unremoved, sir.
for the fibula, for the LCL.
We have just range of movement brace was applied, sir. Should be just immobilize.
Avulsion should be fixed. Who is done? Jairam.
Yeah.
Next.
So 52-year male with closed tibial plateau fracture of the right knee, sir. It is a Scatzer's classification type 5, sir. It's a bicondylar. So we have done open reduction internal fixation with plating for the right tibia.
With ammunition on the medial side, it's safer.
Butter split.
Plate.
Actually, we plan to put butter split, but the swelling is too much, sir. So can't.
Swelling is too much.
We waited for 10 days.
Small fixation.
Okay, sir.
Then it looks good.
Sir.
Next. Done.
One more is
32 years male with 10 years post-op follow-up case of middle third shaft fracture of left femur, sir, with implant in situ, sir. We had done implant removal, sir.
So 3 of you collect the data, pre, post, PFNs, and their telephone numbers. Next 3 months,
Okay, sir.
collect about 100 cases.
Okay, sir. Definitely.
Every day, how many? 100. It takes 3 months, which
Yes, sir.
so probably you should get more than 100.
Okay, sir.
Then we will publish.
Yes.
Okay?
Okay, sir. Thank you.
two more.
You had implant removal.
Yes. So 32 years male with the middle third. Sir?
ఇంప్లాంట్ అయిపోయిందిగా
చేసిన మిడిల్ థర్డ్ బోత్ బోన్ షాఫ్ట్ ఫ్రాక్చర్ ఆఫ్ లెఫ్ట్ ఫోరమ్ విత్ ఇంప్లాంట్ ఇన్సైట్. This is complaining of discharging sinus and
When was it operated?
after 18 months.
You did not mention there.
So this one. chronic osteomyelitis.
dermatitis metal reaction implant loosen అయిందా లేదా
Implant loose.
heal అయిందా లేదా ఇవన్నీ చూడమా
Yes. Yes, sir. Fracture is healed, sir. Sinus is there, sir. Yes, sir.
it only dermatitis or sinus
Sinus is present, sir. And implant loosening, screw loosening also, sir.
lucency all around the screws was the wound healed primarily at the time of the first surgery
Yes, sir. Yes.
no evidence of infection post operation
No, sir.
or even later.
No, only ulnar side. This. Yes.
And what is the definition of surgical site infections of orthopedic implants?
Till 6
Primarily post-operatively the wound has been
immediate.
quite
Yes.
but at a later date
After.
signs of inflammation or infection of this. Is there any time period for definition of the surgical site infection for bones?
6 months.
Anything less than 1 year. 1 year is the cutoff.
Cut.
Unlike soft tissue surgical site infection.
What they have presented in this case is osteomyelitis of this is not correct. That's implant infection only. Implant
Implant.
exam beds the case is they are talking about osteomyelitis of the both bones only. But how can you say osteomyelitis was arguing? This is only post-operative case where the implant got infected. That's an infected implant. But not the osteomyelitis. So how do that got? Is it? There was no sinus at all. Just opening there. Balance tissue was not there. Then if you open it, certain reaction is it. Implant. It exam bed. But asking you this.
67-year male with 8 months old post-op case of intertrochanter fracture of left femur with implant loosening, sir. Last week we discussed. We have done implant removal and bipolar cemented hemiarthroplasty for left hips. Sir?
Mechanics restored here. Mechanics of the hip.
Yes.
Sir, really. But still it is not the offset is decreased horizontally as vertically. Both see the length of this and length of that. Okay, better than. I mean, very near to that. Okay. But there is no other do that do that only.
22-year male with grade 3B compound comminuted middle third shaft fracture of right tibia. Is there bone loss is there, sir? And we have done external fixator for right tibias.
Was the fragment inside now? Anti-fragment. It's gone inside or
Inside, sir.
outside only?
Inside.
Suturing chesara?
Yes.
But you got to put stay sutured only.
Yes, stay sutures, sir. Stay sutures only, sir.
No.
Yes, sir.
doesn't
Right. But
Right.
deformed.
Why this is enough to maintain the length, but that has to heal by itself. Our fractures and the దగ్గరకు వచ్చేస్తే it may go into who knows if it gets infected. But later on you can plan for that. Right now the ideal is to put a X-fix and say wait. Yeah. No. Immediate also. Immediate you put a supplement and then everything, and I think it's big one. The best thing wait till the 6 weeks. It's not uniting. Go for that.
So if the proximal pin is in
Where is it?
the tibial tuberosity or
Outside from that. Where is it? Proximal asking pin.
Tibial tuberosity.
Below tuberosity. Yeah? Why that time? You would have gone a little more medially laterally. Where do you put the pins? Tibial pin? Tibial pin traction, how to put the pin?
2 centimeter below the tibial tuberous.
From lateral medial or medial lateral? Do that.
Lateral to the lateral to medial.
Approximately lateral to medial.
Yes. Why? Why not medial to lateral?
We will get the
Common
direction
and
of the
common.
common periodal nerve injury prevented.
But is it in that position now? He has a doubt that we have gone to the tibial tuberosity. It's not that. Lateral. Yeah. Right.
Yes.
You can see this vertical line. Cross leg flap. Yes. If you are able to do it. Otherwise, call someone to do a flap, cross leg flap. Yes. Close that. Do the flap.
You have to consult the plastic surgeon so that he will plan the flap and the shank pin should not come in the way of the flap plastic. So you have to have a
Away from the pins.
otherwise if you put
Away from that.
plane of the flap transfer, flap cannot be
Yes.
transferred. So in consultation with the plastic surgeon, we will have to arrange the sectional fixate the frame
Close the wound.
such a way that it does not interfere with the flap transfer.
Right.
That is very important.
What is the distance between bone and rod?
This one you mean?
Rods are
Between both. Rod and acha.
5 to 6
Yes, you can even lift it with that.
centimeter.
Or you want to do dressing also, you can do it.
How come the fibula has escaped so much of violence to the tibia?
It's not direct hit on so. Direct onto the direct onto the shin. Yeah.
Must be a very
90.
hard metallic culture.
Right. Hey, that?
What is RIA technique?
Sir?
RIA.
Reaming. Irrigation and aspiration.